Thank you for joining us for tonight's ASPN webinar. We are going to allow 2 minutes for people to log in, and then we will begin the presentation with our moderators, Dr. Timothy Deer and Dr. Dawood Sayed. Again, we will begin the broadcast in 2 minutes. Thank you for joining the ASPN webinar series. We are allowing people time to log on, and then we will begin the broadcast with our moderators, Dr. Timothy Deer and Dr. Dawood Sayed. We are going to start approximately at 6:02 p.m. Pacific, 9:02 p.m. Eastern. Thank you for joining the ASPN webinar tonight. We will now begin the program.
Well, thank you so much, and thanks to everyone for joining us tonight. We certainly appreciate our ongoing discussions with you, and on behalf of Aspen, it's certainly a pleasure for all of us to be here tonight. I'm sharing the moderation duties tonight with my dear friend Dawood Sayed, and we're going to be talking about some important topics. The Aspen webinars began during the COVID initial happenings in March when we had a COVID task force. We had about 2,000 people in the first webinar. Since that time, we've had webinars on many topics, and we've had great faculty. And our faculty tonight, as you see here, we have Dr. Stephen Fulowski, Dr. Andrew Bucks, Dr. Peter Probowski, Dr. Navdeep Jazel, Dr. Alex Escobar, and Zahira Hassani, who's an advanced practice provider. So that's our faculty tonight. And at this point, I'm going to just welcome you and hand it over to Dr. Sayed to go over our agenda and introduce the first speakers.
Thanks, Tim, and thanks to our faculty, and thank you to Vertos for helping sponsor this and providing us the resources to continue to being able to put these webinars out there and provide CME to all our members and people that aren't even our members right now. We really have a star-studded lineup of people I really respect. They're all dear friends and really leaders in the space. And we're excited to really introduce you to some of the evolution of percutaneous interlaminar lumbar decompression. We'll be talking about the evolving body of evidence. We're going to talk about some real-world experience and treatment algorithms. We'll talk about patient identification, and then we'll conclude with patient education and management. And throughout the webinar, we will be asking questions of our expert faculty as they arise, and we do encourage people in the audience to send over questions that we'll try to get to if time allows. So I'm just going to spend the next few minutes just going over percutaneous interlaminar lumbar decompression. Next slide, please. These are mine and Tim's disclosures. So percutaneous image-guided lumbar decompression. So it's a CMS-defined treatment category for posterior decompression of the lumbar spine. It's performed typically under X-ray guidance with the assistance of contrast media to identify and monitor the compressed area via an epidurogram procedure. So this is meant exclusively for symptomatic patients with lumbar spinal stenosis that are unresponsive to conservative therapies. And its uses are specifically designed instruments to percutaneously debulk the ligamentum flavum specifically. Next slide. So the procedure overview, and some of our panelists will go into some of this in more detail, but just from a 10,000-foot view, essentially instruments are advanced through a 5.1 millimeter portal. Again, this is done under image guidance. An epidurogram is used to visualize the treatment area, specifically the epidural space. Small pieces of laminar bone are then removed to achieve access to the ligamentum flavum. And then you go in with a percutaneous tissue sculptor to debulk the tissue and achieve decompression of the spinal canal. The instruments are then removed, so no implants or anything is left within the patient. Pressure is applied. Patients usually leave within an hour after the procedure, typically. Next slide. Potential complications, things can happen if not done properly. These include things like inadvertent dural puncture, nerve root damage, postoperative bleeding, infection, some of the risks associated with local anesthesia, and risks to contrast allergies. Overall, the safety profile remains excellent, and as Dr. Falowski will get into the data, he'll share a little bit more about the safety profile about this. Next slide. So again, some of the key questions we hope to answer during this CME program is, what is the body of evidence for percutaneous interlumbar decompression, and does it support its treatment for spinal stenosis? Where does this procedure or therapy fit in the lumbar spinal stenosis treatment algorithm? All of us perform epidurals many times a week. When do we really move on beyond epidural steroid injections and consider something like PILD? Who is the optimal patient? How do we best manage these patients? And how does that differ from the other therapies that we may provide? Next slide. And with that, I'll give it to one of my good friends and a highly respected neurosurgeon in the space, Dr. Stephen Falowski, who's going to talk about the evolving body of evidence for percutaneous interlaminar decompression. Steve,
Great.
Take it away.
Thank you, Stephen.
Okay, well, thank you very much, Dawood. So what I'm going to try to do, these are my disclosures here. What I'm going to do is try to take you through the evolving evidence that we have for this procedure, and also hopefully demonstrate to you that this is a prime example of how the data actually drove where this is positioned in our space and where it's positioned in the treatment algorithm. There have actually been two large level 1 evidence multi-center randomized controlled trials that have already been performed. We're going to dive into the MIDAS OnCourse study, which was one of those, specifically positioning it against epidural steroid injections. But there's also been several other studies, from retrospective analysis, level 2 evidence studies, very large meta-analysis that have also been performed, all confirming the data that we're going to talk about in the level 1 evidence that we have. But to give you kind of the overlooking impact of what this showed with the data, it demonstrated that there was long-term durability. We're going to look at these studies that follow these patients out for 2 years, and not just an assessment of the pain relief, but also an assessment of function, and also looking at the safety profile of this procedure. We're going to look at the significant clinically meaningful improvements that these patients had. As we know, in our space, we're moving past interventional pain scores. I'm looking more towards functional outcomes in the space, with especially these interventions that we proceed with. We know that that's more accurate than the subjective nature of VAS and NRS pain scores. But what's interesting though too is, then we'll dive a little bit into the safety of this procedure, which actually demonstrates that even up to 2 years, that the safety profile of this matches that of an epidural steroid injection, which is very interesting when you think about it, because when we position this in the treatment algorithm, that is exactly where we are looking to position it against and where it fits in for our patients. So when we go through the MIDAS OnCourse study, which we're going to be going to the next slide now, please. Keep in mind that although we're looking at one of the level 1 evidence studies, that there were 2 level 1 evidence studies, and there's over 30,000 implants that have already been done. And we've studied numerous of these patients over numerous studies as well. So diving into the MIDAS OnCourse study, it was over 300 patients that were randomized to either have the percutaneous lumbar decompression procedure performed, or they were going to undergo the standard lumbar epidural steroid injection. Now, a couple things I do want to point out, and I think this is very interesting, is the criteria or inclusion criteria for the study was to have hypertrophied ligamentum flavum. But what's interesting is that when you actually look at the patients in the study, only 5% of them were isolated to just central stenosis. So although the inclusion criteria dictated that you had to have hypertrophied ligamentum flavum, which would lead to obviously central stenosis, only 5% of the patients actually had this as a single entity. That means the majority of the patients had additional comorbidities or other factors such as foraminal stenosis, lateral recess stenosis. What's also interesting is that having those other factors or comorbidities actually had a positive predictive value, because those patients actually did even better than those with just central stenosis. So keep in mind, although we're treating the idea of neurogenic claudication from hypertrophied ligament, that a lot of these patients have ongoing comorbidities in these other areas, and it actually may be a positive predictive value for those patients. Next slide. So here's when we look through the functional outcomes as well as pain scores on these patients. So when you actually look at the patients who responded to the therapy, one is there was a 5-point improvement in their NPRS score, which is significant. The other thing that I think is actually more impactful is because when we're treating these patients with lumbar spinal stenosis, we're looking at things like neurogenic claudication. From a surgeon's perspective especially, to me, this is the idea of, in the future, protecting the patient's nerves, protecting them from getting worse, but also the goal of improving a functional outcome. And what you see here is there was an improvement of 32 points on the ODI scale for these patients, obviously showing a very significant improvement for these patients. What's nice is that it also held true out to the 2 years. So what you can see here is the endpoints of 6 months, 12 months, 18 months, and then at 2 years. What it shows is even at that first endpoint of 6 months, the same results held true all the way to 2 years, showing durability of the procedure as well. Next slide. And then, as you can imagine, if you can show, one, that these patients have great outcomes, not only in pain scores, but in functional outcomes, you can imagine that the patients would be very satisfied. There was an 85% patient satisfaction rate. I can tell you in surgery, this is something we strive for. We actually have scales such as the Zurich Claudication Questionnaire, which looks at things like patient satisfaction. And sometimes there is a disconnect between patients' pain scores and their satisfaction. However, one of the things we know that correlates very well is patient satisfaction with functional outcomes. So what we're seeing here is where it's the trifecta. Obviously, the patients were very satisfied with the outcome because they had not only improvements in pain scores, but functional outcomes as well. Next slide, please. And then what you can see is we also looked at the safety profile. And now this has been confirmed across numerous studies, as well as in the meta-analysis, is that the safety profile is about as equal to that of an epidural steroid injection. The adverse event rate in the Midas Encore study was 1.3%. There were no serious adverse events that occurred. Now remember that this study was a direct comparison, randomized controlled trial to an epidural steroid injection, and there was no significant difference in the safety between these two procedures. In addition, one of the things you would worry about is that with any type of removal of bone or procedure on the spine is that you can lead to some type of spinal instability. These patients were followed over 2 years in the study, and it demonstrated that there was no spinal instability that occurred with these patients. As many people know, when we do fusion surgeries or even decompression surgeries, you can have as much as a 10 to 20% rate of adjacent level disease that can occur, and a large percentage of those do occur actually in the first 2 years. So this is very significant to show that there is no spinal instability that occurs with these patients. Next slide. Now, just to move on a little bit past the Midas Encore study into some of the other studies that have been published. Now, this is a study by McHale out of the Cleveland Clinic, and this is truly a study to look at functional improvements. And what you see here is that significant improvement in standing time, 7 times the amount, as well as 16 times the amount of walking distance in these patients. And these patients were followed up for 1 year. And also looked at in this study was the fact that their pain levels had improved. So next slide. And then what you see here is a comprehensive safety comparison that was performed by the investigators of the Midas Encore study, looking at other different comparative procedures. And what you see here is that it is either better, or the same, or better than other procedures that you would use in the space, such as implant of interspace devices, surgical decompression, fusion. We know this is a significant reoperation rate when you intervene on the spine with some of these procedures, and you can see here that the the safety comparison is pretty dramatic in favor of using percutaneous lumbar decompression. Next slide. So just in conclusion, I think looking at this data and looking at the data from several studies, you can see that there's obviously durable outcomes, 2-year follow-up in a lot of these studies. It demonstrates the safety, the efficacy of this. It's something that's a minimally invasive procedure. And I think most importantly, what you're starting to see is that this can be used as a first-line therapy, and it's positioned in the treatment algorithm along that of an epidural steroid injection.
So Stephen, tremendous job as always, and certainly with your neurosurgical background, I think it's very enlightening. Dr. McKell and I are leading a national multi-center study, a level 1 evidence study on this procedure right now, and we'll have that data hopefully by the spring. But I have a question for you, and that is, when I educate a patient, I did this procedure today, a 2-level, fairly thick ligament. When I educate a patient based on the current data you just presented, and they have an MRI showing ligament inflated hypertrophy, let's say it's 3.5, 4 millimeters at 2 levels, what can I quote them based on the current data would be their odds of a good result?
I think we see from the study that basically you're going to have about at least an 80% responder rate. And if of those people who respond, they're going to have significant improvements in their pain scores, at least a 5-point reduction, significant improvement in their functionality. And I think what's also important is for something that's just a minimally invasive percutaneous procedure, it's durable. We have results that show that even out to 2 years, these patients still continue to do well.
Great. No, I think that's a great answer. Thank you for that very much.
Stephen, I echo Tim's comments. A wonderful job as always. I want to pivot just a bit and kind of pick your brain as a neurosurgeon, not really talk about the evidence, because there's going to probably be close to 1,000 people that will watch this webinar. A lot of them interventional pain physicians that want to incorporate this into their practice, and they will probably potentially, some of them will get opposition from either their facility or surgeons within their community or hospital or ASC against performing this. What's your advice to those potential physicians on how to kind of overcome those potential political obstacles and incorporating this into, bringing this into a hospital or a surgery center, et cetera?
I think that's a great question, Delwood, and I think it's something that all the interventional pain physicians are going to eventually be faced with doing these procedures, and especially as it grows. I think some of the things that the surgeon is worried about is, one is that there's going to be a significant amount of complications that they're going to have to come in to take care of. We've seen from the data in these studies, they're all performed by interventional pain physicians. The adverse event ratio is significantly low, and it does not require the intervention of a surgeon to take care of that. So that's the first thing. I think it's going to be educating the surgeons on that. The second thing is that they're obviously going to be worried that potentially you're taking cases from them. We have to look at where this is in the treatment algorithm. This is much earlier in the treatment algorithm than what the patients that surgeons are going to see. You're trying to prevent them from needing the surgeon later on. And this is being positioned against that of an epidural steroid injection, which is exactly what every surgeon usually refers out to do. So the last thing is surgeons are always worried that, well, if these procedures fail, now they don't have a virgin spine anymore to operate on. So, the interventional pain physician went and mucked around, and now I have to fix it, and it's considered revision spine surgery. That's not the case at all. This is not creating significant amount of scar tissue. We're not removing significant amount of bone that it now becomes a revision spine surgery for that surgeon. So that's not a factor as well. So I think those are the 3 main factors that you're going to want to address with the surgeons, because I think that's exactly what they'd be worried about.
Yeah, that's
great response.
That's a wonderful response, and just really helpful for me to hear, and for, I'm sure, a lot of people, of our colleagues, to hear kind of how to kind of combat some of that natural opposition that's going to happen. So I think that's a wonderful pivot to our next 2 speakers. Anjum and Peter are going to talk about this treatment algorithm and some of the evidence and their experiences. Guys, the floor is yours.
Thank you very much. So the question is where do epidural steroid injections fall in the treatment algorithm for lumbar spinal stenosis with neurogenic claudication? What role do they play? And really, when do we move on from epidural steroid injections to percutaneous image-guided lumbar decompression? Now, as you can see, there certainly is compelling evidence in the New England Journal of Medicine and Clinical Journal of Pain, and studies showing that epidural steroid injections have no beneficial effect on neurogenic claudication symptoms compared to local anesthetics alone. We've also seen in a study by Dr. Peter Stotts that epidural steroid injections do not provide long-term relief for patients with central canal stenosis. And repetitive epidural steroid injections may provide short-term relief, especially for the radicular components of pain, but really do not address the root cause of the stenosis, which, as you can see from this image, is the hypertrophied ligamentum flavum. This is really what's causing that narrowing or triangulation in the central canal. And to really treat these symptoms of neurogenic claudication, decompression is really required to relieve this pressure. Furthermore, another concern with epidural steroid injections, especially during this COVID-19 pandemic, is that steroids, induce immunosuppression, increasing susceptibility to infection. So most of us now are either avoiding steroids or limiting use certainly in patients at risk. Next slide. So, what are the advantages of percutaneous image-guided lumbar decompression as an early treatment option? As you can see here, and what Dr. Falowski said, it's as safe as an epidural steroid injection. It's minimally invasive. There's no implants. Again, there's minimal tissue trauma. Basically, these patients leave with a Band-Aid, and really, I don't give them anything for post-op pain relief. They walk out of the surgery center or hospital really pain-free. It is a steroid-free procedure, thereby limiting immunosuppression. Most of my patients are done under local with some sedation. There's no need for general anesthesia, and there's no need for a hospital stay. All of these are outpatient procedures that are, again, patients walk out 30 minutes to an hour after the procedure. There's no contraindication for patients with osteoporosis. It's the lowest complication rate versus other lumbar spinal stenosis treatments, low reoperation rates, and we've seen clinically significant long-term improvement in functionality, mobility, and pain. And we're not disrupting anything. There's no limitations regarding any other future interventions. Some of the limitations of this is basically this is indicated for treatment of stenosis secondary to ligamentum flavum hypertrophy. If a patient has had previous surgery at this site, there is a contraindication to performing the decompression at that site. And there is some radiation exposure during this procedure. So now the question is, really, when do we incorporate percutaneous image-guided lumbar decompression into our treatment algorithm for lumbar spinal stenosis? One option is moving directly to PILD after diagnosing neurogenic claudication based on symptoms and MRI with ligamentum flavum hypertrophy. A second option is to do an epidural steroid injection first, and at 2 weeks follow up if the patient's not at least 50% better, then moving to PILD. And a third option, which is what I do in my own practice, is to evaluate the patient, and after diagnosing neurogenic claudication based on symptoms and MRI findings, I choose to do an epidural with an epidurogram to look at the anatomy, assess the levels of stenosis in a contralateral oblique view, and move to PILD if appropriate. So with that in mind, I will pass on the next section to Peter to go over his retrospective study.
Great. Thanks, Angela. Appreciate it. Just want to thank Tim and Dawood for inviting me to speak tonight on PILD. I've been doing these cases both in an academic institution and then recently in private practice. So we're going to just review a series of 47 patients we've identified. Most of these patients come from Q3 and Q4 of 2019, and kind of how we've been treating these patients, I think a lot of us as interventional pain specialists sometimes get into a rut of doing lumbar epidural steroid injection after lumbar epidural steroid injection. So, I did a retrospective review of some of the patients I've decompressed to assess how many epidurals they actually underwent before undergoing the decompression, and whether or not they affected their outcome postoperatively. Next. So it's 47 patients that I retrospectively reviewed. The mean age was 70 years old with the range from 40 to 92. Most of my candidates were female, 66% compared to male, 34%. In terms of spinal comorbidities, I think this is a very important topic to highlight with tonight's talk, and Stephen mentioned it before. I think there's a lot of pain doctors out there looking for that perfect candidate who only has ligamentum flavum hypertrophy with central spinal stenosis. And we know both from the Midas Encore data, that's not the truth, and that doesn't really exist in the real world. A lot of these patients we treat have other comorbid conditions that are creating their spinal stenosis. The patients I identified obviously all had hypertrophic ligamentum flavum hypertrophy, and that's why they were decompressed. But you can see the majority of my patients had bulging discs, half of them had disc herniations, another half had facet arthropathy, 40% with facet hypertrophy, 20% with lateral recess stenosis, and also 20% with foraminal narrowing. So although we are targeting hypertrophic ligamentum flavum with this percutaneous decompression, these patients that we're treating all have comorbid factors, and that actually doesn't take them away from getting this procedure. It actually, in the clinical data, shows that they can actually have a lot of relief with this procedure. So I think, the word on the street used to be that this procedure only treats central stenosis. But in looking at the data, both from the Encore study and my own personal data, we see that isn't the case. Typically, the levels I'm treating are 3, 4, and 4, 5. I typically do a bilateral decompression. I have treated 5-1. There's some patients we've gone up to L1, L2, and some patients we've treated at L2, L3. So by level treated, you can see about 46% had 1 level treated, 2 levels, 50% of patients, and 3 levels were 2% of patients. Next slide, please. So this was the retrospective review. I just wanted to see, so patients who've had prior lumbar epidural steroid injections, whether it was 1 or multiple, we can see that it really did not change their VAS score from baseline to 3 months post-op after being decompressed. So this is kind of just a little bit more data showing that we really shouldn't wait to be doing multiple epidurals, a series of epidurals, before doing a percutaneous decompression. We're using a 5.1 millimeter portal. This procedure we know is as safe as an epidural steroid injection. My patients go home simply with a steri strip on their back, and a lot of them come back to the office wondering what was done to them because they feel so well and there's minimal scarring. There's really not any evidence of what was done on their back. So we can see that the VAS outcomes post the decompression do not vary based on previous epidural use, whether that was a series, multiple epidurals, or a single epidural. A cumulative effect dose of epidural steroid injections prior to doing percutaneous decompression does not improve any outcomes that we saw. And we really should advance to percutaneous decompression to avoid delays in care. I think Steve mentioned earlier, these patients, they tend to be elderly, Medicare beneficiaries over the age of 65, and they really want a better quality of life. So when I'm talking to my patients about percutaneous decompression, it's not necessarily about more about the ability for patients to stand longer and walk longer and do their activities of daily living with greater distance, being able to travel and stand with less pain. Next slide. So using our data, both from the Midas study and then the data I generated in the practice I treat out of in the Philadelphia area, we see that repeat epidural steroid injections, all they're really doing is just delaying treatment of neurogenic claudication, doing the PILD. So multiple epidurals prior do not improve the outcomes postoperatively and actually delay the patient receiving appropriate care that can give long-term durable outcomes for them. So we're trying to eliminate or reduce the use of multiple repeated epidural steroid injections. So for neurogenic claudication patients, physicians in my practice, like myself, have either completely gone away from doing a series of epidural steroid injections or even a single epidural steroid injection. If I'm receiving patients, sometimes I'm the 4th or 5th pain doctor someone see, I'm not going to repeat a series of epidural steroid injections. I'll go right to a percutaneous decompression procedure. So our experience in my private practice setting actually mimics what's out there and published in the data. So we know that the procedure is as safe as an epidural. All the patients I've done over the last 4 years, I'm lucky to say I've never had any complications from those cases, which is great. When I talk to patients about the procedure, I really tell them, listen, you've had epidurals before. This is not going to be any worse, and it's just as safe as the procedures you've had before. We know that the effect of epidural steroid injections on symptoms of neurogenic claudication are limited and they're short term. And we, as Andrew mentioned earlier, patients receiving steroids do have increased susceptibility to infection and immunosuppression. So the great thing about this procedure, you don't have to use steroid. If you're worried about taking referrals from your surgical colleagues, I'd encourage you to go to your surgical colleagues and say, give me the patients you don't want to operate on and see what I can do for them. And you'll be impressed, and the patients will go back to those surgeons, and then all of a sudden you'll see surgeons start to refer more and more to you for patients they don't want to operate on. You can truly help when you do the decompression procedure. So spinal comorbidities are not contraindicated. So if patients have disc bulges, disc osteophytes, facet arthropathy, facet hypertrophy, that doesn't preclude those patients from getting a percutaneous decompression. Those patients tend to do very well after we decompress them.
Pete, that was a great talk. And Anjan, thank you so much. We have 2 questions apiece for the 2 of you. I'm going to start with you, Pete. Leo Kepper and I did the first of these procedures of non-surgeons about 10 years ago. And I agree with what you said. My surgeons and I, we have a great relationship. And certainly we talk about the algorithm, and certainly you can find a very good place where patients do well. The question for you is, it comes from one of our viewers, is how can you repeat this? Let's say you did a procedure in 17, they're part of your retrospective study, they did very well, and now they come back to you in 2020, 3 years later, and the ligaments thickened up again or at a different level. Can this be repeated? How often, and how do you make that decision?
So it can be repeated. I've never had to repeat percutaneous decompression at this point in my career, but I have talked to other physicians around the country who have repeated it, and I believe you can repeat it 12 months after the original procedure date takes place.
Very good. Dawood, do you have a question?
Yeah, fantastic job to the both of you. My question is for Anjum. You spoke to your algorithm on how to kind of identify these patients that present with LSS or spinal stenosis. Now that, there's obviously, we went several years without really having really good tools as interventionalists for LSS, but, over the last few years, we actually have 2 commonly used tools. One, an intraspinous spacer for decompression of the canal indirectly, as well as this, a more of a direct decompression. How do you kind of choose when to do what? Because that's a really hot button topic that comes up at all the meetings and on the conferences. How do you kind of make that clinical decision in your practice?
Certainly, I think it's a great question. When these patients present with neurogenic claudication symptoms, I think, we certainly need to look at the MRI and see what's causing that. They have central stenosis, lateral stenosis. Is it certainly caused by hypertrophied ligament and flavin? And if it's caused by that, I will certainly do an epidurogram to look at the levels of stenosis. And with this procedure having no implant, being minimally invasive, with a hypertrophied ligament, percutaneous image-guided lumbar decompression would be my first choice to go to. If I did not see a hypertrophied ligament, then I may consider something else.
Great answer. I agree with what you said. Anjum, I'm going to have a question for you, and then the last question will go to Pete from Dawood. My question for you comes from the audience as well, but I'm going to interject a 2-parter here. When I first started doing this procedure, we would put dye in the epidural space, and we would take some bites, and we put some more dye in. And And over time, we learned that we really could put a very low volume of dye in, and as you decompress, you see the spread. So like today, I did this procedure. I used 4 cc's of contrast for 2 levels, but I saw a great opening once I was there. So part one is, do you think there's a necessity to continue to use more contrast, or can you use less? And then the second part of that is, do you get better and quicker with time? Because one of our colleagues said their surgeon center didn't want them to do this procedure because they thought they would be too slow. So is there a learning curve, and do you get better and quicker?
Certainly. And, you know, the way I've recently transitioned to these procedures now is I'll inject some dye initially, and I really won't inject any more throughout the procedure. What I have found is I've taken some of the lamina and some of the ligaments off. As it's opened up, I've seen that dye spread without me even injecting anymore. So certainly you can use lower volumes of dye to achieve what you want to achieve and see the spread. And with time, I certainly have gotten quicker. I've moved to a single incision technique where I'm able to get 2 levels bilaterally through one incision. So I do 1 epidural stick at my superior level, and then through my access trocar through a single incision to get both levels on both sides. These certainly have been quicker. I'd say about 30 minutes for bilateral 2 level.
Very good. No, great thoughts.
That's great. Yeah, Peter, I had one question for you. I think for those of us we're kind of contemporaries, same generation. I feel like when mild was first introduced, it seemed to have kind of a restrictive indication, pretty homogeneous. You know, we were kind of looking for patients with purely ligamentum flavum hypertrophy in the central canal. But as the data and as you shared your kind of personal experience, it seems like it can be effective for a rather heterogeneous patient population. So my question for you is, when do you not do mild?
Yeah, I think Anjem kind of answered it already. I mean, I don't do mild on patients who have no hypertrophic ligamentum flavum, right? If it's 2.5 millimeters or less in my book, I'm not going to do a mild on them. And patients who've been, you know, if they have fusions, I'm very hesitant to treat any patient who's been instrumented or who's had previous surgery on their low back. You know, the nice thing about the mild is, number one, I can do it on a really elderly population. I mean, I've done this on patients in their 90s, right? Because we can use minimal anesthesia, just be very heavy-handed with the local anesthetic and do a good decompression. So there's a lot more people that fall in the category that would have being able to be treated with this procedure than being excluded from being able to be treated from this procedure. And like I said earlier, if you're just looking for that unicorn that has central spinal stenosis with hypertrophic ligaments and flavum, it's very hard to find. And I encourage those watching and listening to not try and find that unicorn. No, you can have success with these patients who have these other stenosis comorbidities present.
Pete, is there a BMI cutoff for you? Do you have a cutoff above the BMI you won't go?
Yeah, I mean, Tim, these are the patients that the surgeons don't want to operate on. So, I mean, if my C-arm table can't hold the patient, then that's my cutoff. But I will always try to do my best and give it my best shot to do a good decompression for people.
Very good. Agreed. Good job. Okay,
Gentlemen,
Dawood?
Yeah, gentlemen, great job. We're going to pivot now to Dr. Jasal, powerhouse young physician in Tampa Bay, Florida, who's going to talk to us about patient identification for this therapy. Navdeep.
Thank you so much, Tim. Thank you so much, Dawood. I mean, what an excellent CME event, and what an excellent presentation so far from Anjem, Stephen, and my colleagues, Peter. Next slide, please. So now let's talk a little bit about some of the fun stuff. The fun stuff are the typical PILD patients. Let's identify them. Your patients, as were described earlier by our colleagues, are going to be our senior patients. They're going to be our elderly, Medicare beneficiaries, your Medicare Advantage Plan patients. The patients that are predominantly 60 years or older, they have a degenerative condition. And we're going to talk a lot about spinal comorbidities as well as cardiovascular comorbidities. These patients all have them. These patients are oftentimes very limited in terms of their function with mobility. and they have a very strong lower diminished quality of life. And their often presentation is going to be neurogenic claudication symptoms. So let's just define that so we all understand that, because it's very important to pick the right candidate for the right therapy. So our patients are going to present with pain, numbness, heaviness, and they're going to feel tingling in their lower extremities. In the lower extremities, they can feel it in their proximal thighs. They can feel it in their distal lower extremities. It just really depends on the patients, but clearly they're going to have pain worse with extension and absolutely improvement with some sort of forward flexion. And so those are very key characteristics that you're going to identify when taking a careful history examination of your patient. Ask for things like, are you using the shopping cart when you grab and go at the grocery store? Does that allow you to walk farther? Does it allow you to stand farther? Are you sleeping in a fetal position? These are all really important characteristics for identifying neurogenic claudication symptoms. The other things that you're going to look for, and patients that come into my practice, I'm sure they're going to come into your practice, they've failed multiple conservative therapies. They failed the standard things, the non-steroidals, the over-the-counters, even low-dose opioid therapy, which really has zero evidence to prove that it works for neurogenic claudication symptoms. They've tried a great forward flexion physical therapy-based program, and they've tried our epidural steroid injections, as our colleagues have mentioned today. Please keep in mind, again, this is a compression phenomena. This is not an inflammatory phenomena. We are talking about neurogenic claudication caused by compression of your spinal nerves. Next slide, please. Let's talk about some additional patient selection considerations. So we talked a little bit about the obvious, and let's talk a little bit about the less obvious. So again, we mentioned that because of age, our lumbar spinal stenosis patients are going to present with cardiac as well as pulmonary diseases. These patients are going to be the COPDers, the ones who are on baseline O2. These patients are going to be the ones that have stented before. Maybe they have a pacemaker, maybe they have a defibrillator or a pacemaker. So these are your typical types of patients, and these patients are not contraindicated in any way for PILD. In fact, it's safe to do something like the PILD procedure, secondary to the fact that you are using a low dose or a low amount of anesthesia. And a lot of times these patients can be done with, as Peter said earlier, very heavy-handed local anesthetic. The options for these patients are very broad spectrum, the options for PILD are really for these broad spectrum types of patients. Your patients can be treated from all ends of the spectrum. They can be from mild all the way to severe stenosis. So my typical patient population presents in Florida with moderate to severe or severe central canal stenosis. These are excellent candidates for decompression because, again, a small amount of change of volume in that little central canal is going to offer a strong amount of pain relief as well as functional improvement for your patients. Patients who are unable to tolerate surgery, we talked about our patients with high amounts of BMI. When is it necessary to not offer this procedure? Again, Peter said it so eloquently, when they can't actually fit on your table. It's patients with severe osteoporosis or those that can undergo heavy general anesthesia or heavy anesthesia in general. These patients are great PILD candidates. We talked a little bit about hardware. Well, Steve mentioned earlier that when a patient undergoes previous lumbar spinal fusion, the adjacent level often has spinal stenosis that may develop over the course of some years. These patients are still candidates for PILD therapy. And patients often have instability. And let's talk about grading. We all know about grade 1, and let's talk about grade 2. Well, patients who are up to grade 2 can also be treated with PILD therapy. And please don't forget about your patients that you routinely do epidural steroid injections. I would advise you guys all and gals to really order an MRI, a new one, an updated MRI, and look at your MRIs carefully and examine to see if you can offer this therapy earlier in the treatment algorithm, as we all understand that the evidence supports the fact that they have long-term durable outcomes with PILD therapy. Next slide, please. I want to summarize a little bit about some of the take-home points. When we identify a candidate, we talked carefully about really identifying the right type of candidate with neurogenic claudication symptoms. It's important. The second thing we're going to identify on an MRI is going to be central canal stenosis, and we're looking for a hypertrophied ligament that's at least 2.5 millimeters thick. That's really the baseline. That's all you need to start to have an impact for a patient with these neurogenic claudication symptoms. And also you're looking for stability and access. So many times with my patients, not only am I looking at the axial T2, as well as the sagittal and the parasagittal images to allow to look for access points for my trocar, I'm also doing a flexion extension film just to make sure I don't have any instability at that segment that's more than grade 2, because those patients are not treatable for PILD therapy. And again, if you're not comfortable reading the MRIs, which I think is very easy to do with just some practice, please, I encourage you guys to choose a radiologist, have a discussion. And a lot of times they're not just used to identifying or actually marking the impression on for a read for ligamentum flavum buckling or thickening of the ligamentum flavum. So if you have a friendly discussion with your local radiologist, I'm sure they'll identify, maybe even choose to do measurements of that ligament on your report. So if I could hit any point home, is really careful patient selection, reading your MRIs and reviewing your own images to look for the ligament, because it's really not commonly identified on a report itself, but it's very easy to identify. Next slide, please. Next slide, please. So let's talk a little bit about my own single center experience. Peter had some great data, and I want to present to you some of my data. Next slide, please. So these were actually some data sets for my first 33 patients that I treated in 2017 into 2018. I still am, and I was a very younger physician earlier in my career. I was literally only a year and a half out. And this proves a take-home point that anyone can really adopt this therapy into their practice with safe and durable outcomes. Notice that my patients were very similar to Peter's patients. All of them obviously had to have hypertrophy ligamentum flavum to be treated, but they also presented with multiple spinal comorbidities, facet hypertrophy, foraminal stenosis, and degenerative disc disease. In fact, most of my patients presented with these cofactors. So one thing that I really like to drive home is really overcoming some of the misunderstandings with PILD procedure. You should really expect comorbidities in your patients. And again, this really coincides with some of the Midas Encore data that shows that only 5% of our patients really had central canal stenosis, but realized that they had really robust long-term durable outcomes when those people were treated with PILD therapy. Notice my 6-month follow-up had reduced opioid reduction, which we all are hoping to see with our patients, as well as durable VAS improvement for our patients. So really, this really taught me earlier in my career that I should sort of revise my therapy. Am I really doing a series of 3 on my for my patients with spinal stenosis? Is there any outcome to prove that that's really going to help a compression phenomena, or should I change the way I treat my patients and offer them perhaps PILD therapy earlier in the algorithm to offer long-term durable outcomes as well as functional improvement? So those are things that I think I'd like to highlight. I want to highlight 3 other facts, or maybe some misconceptions that somehow people have, is that L5S1 actually can be treated with PILD therapy. In fact, many times it's actually the only option to treat L5S1 stenosis secondary to hypertrophic ligamentum flavum. The other thing is I really like to highlight that osteoporosis is not an exclusion factor. In fact, it will not negatively affect the outcomes of your patients. And secondly, I think Stephen said it really well, is it really doesn't burn bridges at the end of the day. You really can offer procedures and therapies to your patients if they need to in the future, because we are dealing with a degenerative condition. So I expect these patients to have some pain at some point in the future. Next slide, please. I'd like to close with the case study. Next slide. Let's talk a little, very briefly about an 82-year-old male had, again, multiple comorbidities such as diabetes, CAD, had had a stent in the past on Plavix, had tried multiple treatments, things that we all typically think of from another prior physician in New York, who's an excellent, fantastic colleague of mine who did a great job working up this patient. Patient's just not a surgical candidate or a great surgical candidate because of his multiple comorbidities, as well as some of his weight factors. Also of note, he's tried many medications, including the standard treatments like Medrol packs, etc. Notice this patient had severe 10 out of 10 pain, and really could barely walk about 15 feet without a cane. And his pain clearly improved with forward flexion and bending forward. So again, driving home the points of an appropriate neurogenic claudication patient. Next slide, please. We talked a little bit about really understanding and reviewing your own images. I just wanted to put this coronal for nothing else, just to show this patient had other spinal comorbidities such as levoscoliosis. This one has sort of an apex at L2-3. If you notice that the on the sagittal or parasagittal image on your right here on the screen, that at L2-3 the patient had a synovial cyst that really didn't contribute to much canal stenosis or to his issue himself, but at L3-4 you can see a significant amount of degenerative disc disease. At L4-5 you see a grade 1 anterolisthesis that was also confirmed with a dynamic X-ray flexion extension that I would recommend for you to do for your patients with any sort of listhesis, whether it's antero or postero. So really driving home the point, try to read your own MRIs, identify that ligament, that thickened ligament, really on this sagittal as well as an axial, which I haven't shown in this slide, but it would be really nice to review an axial image to bring home that point. Next slide. So again, in terms of before we talked about, let's talk about 18 months post-op, because that's the most important. We want to make sure that our patient has safe and efficacious results, but not only that, but make sure they're durable. This patient was able to walk 1/4 of a mile without a cane. That is significant improvement from prior. In terms of medication, he was not on any. He wasn't on meloxicam, he wasn't on any anti-inflammatories or any other analgesics. This patient also underwent no other treatments, no trigger point injections, no epidural steroid injections, no other procedures that we would offer standardly for our patients with lumbar spinal stenosis that we would have treated in a standard fashion in the past. And this patient continues to offer have really durable pain relief outcomes with an improved quality of life. So, when we offer a therapy to our patients, we oftentimes want to offer a therapy that we would offer to our own family. And I think not only is this clinical experience very important for this patient, but the next slide, please. This really drives the point that I try to offer a therapy that I would offer to even my own family. And this patient specifically happens to be my father, and who's now 83 years old, who's happy to hold my son, who's a very rambunctious little kid, but he's able to have an excellent quality of life. And that's really what it's about. So I appreciate your time. Thank you so much.
Wow. So Navdeep, your dad looks great. You have good genes, my friend. I think you're going to do well long term.
Thank you.
We have time just for one question each for you before we wrap up with the last panel. My question comes from the audience, but I think it's a great question. Over the years, we've learned we can do things like facet denervations on someone who can't come off their blood thinner. But the question is, can you do this procedure, or would you follow the ASR guidelines to take people off anticoagulation?
That's a great question, and oftentimes, I deal with this with our patients. Typically, I'd really like to hold some the anticoagulation. I've had one patient in particular that we had a risk-benefit ratio who was severely compromised, had strokes and cardiovascular compromise, who needed an L5S1 and L4-5, and I did proceed with low-dose aspirin therapy. But typically, I'd like to hold my blood thinners on my patients for risk of maybe an epidural hematoma. Again, we are posterior in elements for everything that we do. In fact, the most invasive part of the procedure is an epidural steroid injection. Maybe I should revisit that, but really it's a safe procedure overall. But I do try to follow and hold anticoagulations as I would with an epidural steroid injection. That's something that I follow.
Very good. Dawood, do you have a question?
Yeah, Navdeep, excellent job. Questions come from the audience, and I know that you're not a reimbursement specialist or a coding specialist, but a lot of questions are coming about how to appropriately code for this, what insurance covers this. I know that you've kind of, you run your own practice, so I think maybe you'd have some really unique insight on just some of the basics around, how to incorporate this from just a coverage standpoint.
Sure, I'd be happy to answer that. So just in private practice alone, I follow every one of my EOB statements. I think it's important to know what we're getting reimbursed on, because we're not going to be able to offer this therapy to our patients, no matter how good it is, if it's not being reimbursed appropriately for providers as well as surgery centers and hospitals that we employ the therapy at. The coding is very simple. It's 0275T as in Tony. I followed every one of my patients. Everyone has been paid. Typically, your patients are Medicare beneficiaries. That is a covered entity, and that also means Medicare Advantage plans. So in Florida, it's very heavy with Medicare Advantage plans, and those supplement plans are covered as they would for any other Medicare beneficiary. Also note that one of the changes from last year, I believe in 2019, allows that age is not an exclusion characteristic. So in the past, we could only treat, I believe, 66 and over. A lot of our patients fall under that that guideline of 62 or even 60. Age is not a preclusion for the treatment. So anyone who's Medicare can be treated with any age.
Great job. Great job. I really appreciate it.
Thank you
Thank
both.
you so much. Dawood, our next panel and our last panel.
Yeah, absolutely. So to round out today's panel, which has been really informative for myself, and I'm sure the rest of the audience will have, my nurse practitioner, Zora Husseini, as well as one of my closest friends in the space, Alex Escobar, talking about patient education and management.
Awesome. Thank you, Dr. Syed, so much. Very as a nurse practitioner alongside of all of you fabulous physicians as well. Dr. Escobar and I will be discussing patient education, as was mentioned. So basically, we really, I can't, I guess, stress, and I think it's been discussed in the past few slides, how important education is, but then also early education. Usually by the time a patient comes to us as interventional specialists and the physicians who do these interventions, they've sometimes tried conservative therapies or been told, like, here's the options we have, and then from here forward it's surgery, or they'll hear something that, you know, sometimes might scare them. So we can offer so many multiple therapies, so it's important to let the patients know what you can offer, what comprehensive care you can do, what might help them, giving them kind of a sense of hope that, you know, if treatment X fails, for example, an epidural or physical therapy or these medications, that it doesn't mean that's their last option. There are other things we can discuss, and so treatment Y or Z can be further discussed with you as well. So giving them just kind of that idea that there's more to come. So early education, letting them know. Establishing really expectations is very important as well. I think it's, you know, key to let a patient know that here's what we expect out of this treatment, here's how this treatment will work, how we function in our practice, how we will move forward if this doesn't work. So those are important pieces as well to make sure you discuss early on, and really establishing a continuum of care, being an advocate for the patient and not for a procedure. So how do you be an advocate? What does that mean? Again, I think if you can educate a patient, help them understand the process, what their diagnosis is, kind of listen to their concerns and address that, usually by offering them options and solutions, then you help them be a part of that as well, and then advocate for their best interest. So with the PILD option, I think the nice thing about this is really that there's not a lot of specific restriction or education that goes beyond, you know, some of the other treatments we have do have a lot more of that. So there's no implant or device that's needing to be managed. It's not a time-consuming education to give. So when you talk about these things with the patient, it's nice that you can say, you know, there's really not a lot of significant follow-up. We're doing this outpatient, you're coming back in just to check the wound, which is not necessarily something that's really being stapled or sutured. There's no implant device. Consultations and follow-ups really are more to just assess how they're doing. There's not a lot of industry involvement. There's no reps that need to be there to reprogram things. So it's a pretty low risk safety profile as well, similar to ESIs as we've discussed. And also this doesn't restrict their option to choose other things to do later if this wouldn't work, for example, or if they had other problems to address too. Next slide, please. So with early education and kind of talking to the patient and kind of going through these management steps, I personally always really take time early on to talk to my patients about their condition. So this is what you have going on. This is what I can see might be contributing to your pain, likely causing symptoms. Here's the diagnosis that we, will attach to that. And here's what can be done to fix this problem, from a most conservative treatment like a physical therapy or medication optimization, all the way through surgical treatment options possibly. So I discuss that algorithm with the patient and let them know that, here's what we can do and here's some things to look forward to. When we do present this option, again, you really have to prepare and set expectations for the patient to understand what it is we're trying to accomplish, really just kind of setting goals for what you can do for them and then helping them understand what role they play to help accomplish that as well. So, here's how the procedure works. Someone from our office will call you when we get this all set up. Here's what we would expect to see as an outcome, and kind of discussing that postoperatively. It's important, I think, also to let patients know that just by doing this procedure doesn't fix everything. You do need to take your part in doing some physical therapy and reconditioning and the follow-up appointments. Here's what it will entail, which is definitely minimal, but also kind of setting that expectation for them to do their part as well. Next slide, please. So with education, again, with the first visit I mentioned, I think it's extremely valuable to take time during our first visit with the patient in discussing this, to educate them and explain what it is that they have going on. I can't tell you guys or anybody, my folks that I precept or just other providers, it's so often that I hear a patient will tell me, you're the first person who's actually sat down and explained this to me, as far as looking at the film, showing them what's going on. I'm personally a very visual person, so I feel like it really helps when someone shows something to me other than just telling me. And this is a great tool or way to accomplish that by sitting down with them, kind of showing them what their imaging looks like, review the MRI with them on the screen. Don't just kind of tell them what's happening. I think that's really valuable to educate them early on. And then that helps them to understand what's happening. And then also, of course, meeting those expectations then down the road for what to expect out of this therapy. Next slide, please. So again, just reiterating to outline that treatment plan with your patient. What can we offer? Obviously, this particular procedure may not be the first thing you're going to tell a patient, especially if they've not tried physical therapy or other conservative treatments. But let them know it's an option. So especially if you get those folks who are very resistant to doing temporary procedures that aren't going to fix the problem, I hear so often. They want a fix, they want it corrected, they don't want a patch for it. So again, talking to them about what we can offer and what we can do to help. Here's an opportunity to try an injection or medications that we might optimize for symptoms. And if those don't work, the next step that we would suggest would be something less aggressive than a major surgery, but a little bit more entailed to correct the problem, which would be this particular percutaneous approach. So just discussing the expectation of what the next step would be in that therapy or that plan so that they know that something's available. And I really stress this a lot when I talk to people, because I feel like there's been times when patients have come into our clinic and then they don't come back because what they heard or what they perceived with the education they were given about, let's say, a surgical treatment, for example, it scared them, and they felt like, well, if that's the only thing, I think I'm just going to live with this and not worry about any other options at this point, or not go through that particular option. So it's important to make sure that you've given the patient those ideas and treatment plans up front during that initial visit and educating them. With that, I'm going to turn it over to Dr. Escobar to go through some more solutions with education.
Thank you, Zora. I'm honored to be here with you all tonight to discuss a therapy that's really changed lives, and I've witnessed it since fellowship. Unfortunately, during my year of fellowship at the Cleveland Clinic, we didn't have reimbursement for the posterior decompression, and it wasn't until the very final few months that it was renewed. Therefore, all the fellows were very eager to identify appropriate candidates so that we would get exposure to the technique. As interventional pain physicians, it's been very common to have palliative options, and like Zora mentioned, only patch the problem and not have a solution. So it's nice to have now definitive treatment options that we can offer our patients. When we educate our patients about the options that they have, you have to be mindful that you don't want to give them too many options. I think it's important that we outlay a menu of potential possibilities that we will offer them. However, you don't want to overwhelm them and plan the next step with them prior to evaluating the efficacy of the treatment that we see. But we know with lumbar spinal stenosis being a mechanical process and not an inflammatory condition, epidural steroid injections may temporarily relieve those radicular components, however, not truly addressing the neurogenic claudication. It's also common that patients run into the routine of a series of 3 epidural steroid injections, which we found is that many of these patients will seek alternative providers or alternative centers for treatment if that's the only treatment being offered. So it's important that we move forward with a definitive treatment when we identify ligament inflated hypertrophy, and also set those expectations for the patient that we're seeking functional restoration. And as seen by the body of evidence, we're improving standing time and walking distance for these patients. And these are objective measures that they can measure, as well as their family, which is sometimes the most rewarding part of the process when you hear that their significant other is happy to go shopping or go to church with your patient. So when we consider a therapy, especially a new therapy to incorporate into your practice, you look at safety, you look at efficacy, and also cost effectiveness. For patients, that's risk, benefits, and alternatives. We have hit all 3 marks with a posterior indirect decompression. And for patients, they feel very reassured when they're told that the risks are very similar to a technique that they undergo routinely without thinking twice. Patients do want to have the least invasive options, and there's a big phobia about spine surgery. Therefore, we need to be advocates for our patients in terms of identifying myelopathic features or patients who likely should seek an open decompression. Now, with the coverage that we have with CMS, most of our patients have been deemed too high risk, and the benefits of a direct decompression is that we can offer this to patients with minimal procedural pain, minimal to none. Also, restrictions are typically activity is tolerated within the first 24 hours, no sutures, no implants, and really a low risk procedure with a high potential for success. Next slide. Collecting baseline data for these patients is critical. There should be templates that are built into your electronic health records that identify standing time and walking distance, as well as simple hobbies or ADLs that patients are previously privileged to that no longer can perform. Most of our patients are quite happy being sedentary, and so what we want to do is promote activity for these patients, and like Zora mentioned, setting those expectations that patients also need to do their part. There's a term we use, you have to move to improve. And so what we find with that is that patients get encouraged and motivated to participate in physical therapy and other modalities when they can measure or track it. So identifying pre-procedural standing time and walking distance, VAS scores, as well as ODIs are something that we capture routinely in our practice. And then those quality of life features that sometimes are the most important to our patients. And especially when we're looking at satisfaction, I can tell you if you identify these patients well and you perform this procedure effectively, your patients will be satisfied with their outcomes. Next slide. So explaining the procedure, I hear a lot of times there's no definitive endpoints with this procedure, and I challenge that by saying each step in the process of this technique is an endpoint in itself. The epidurogram being the first part of the endpoint, which you want to seek a potential barrier or a sort of boundary that you don't want to pass. The next step being the minor laminotomy that we are performing with the Rongere at the inferior and superior lamina at the treatment level, followed by a tissue sculptor that will debulk and remove some of that ligament. I do speak to patients in terms as such, if they're willing to listen. Other patients just want to hear that you're going to scrape out some of the bony structures, and that is enough. But I want to talk to my colleagues here to say that each point in this process has an end point. And we've identified the most effective way to offer this for both physicians and patients to undergo routinely with minimal postoperative pain. All of our patients are doing this under IV sedation or monitored anesthesia care, and typically do not require any anxiolytics. Most of the time, it is a very minor dose of fentanyl, and rarely ever do we use propofol. The local anesthetic is typically enough for these patients to undergo this safely and recover quickly. Next slide. So looking at sort of the 3 steps of post-procedure, a lot of times we want to offer a therapy that we can leave the patient to sort of self-monitor. It's important for us to capture these outcomes, especially for good outcomes. I think what I tell my patients when I don't see them, things are going well. However, we need to be following up at least every 3 months, even in good outcomes. And so what we want to do is make sure that we're capturing the outcomes of those patients that do well and not letting them get lost to follow-up, because what we will find is that a lot of our patients will have other pain generators that we can treat effectively if they're aware of those options that we have prior. So setting those expectations, making sure that you're instilling a reconditioning program for these patients. And we've developed a sort of quick and easy walking program, as well as stretches and exercises that are based on the American Heart Association, as well as the American Academy of Orthopedic Surgery. Follow-up for this is typically at 2 weeks for postoperative checks, wound checks, which are typically minimal to no scarring. This is closed with a tegaderm, and no sutures are necessary. The 4-week follow-up is important to establish whether or not you are going to instill a coordinated physical therapy program. Patients that are home runs and doing extremely well can proceed with a progressive walking program, as well as core strengthening and hip flexor strengthening, flexion-based exercises that we'll see on the next slide. Move to improve. I can't stress that enough. Looking at this for functional restoration and not just pain reduction. However, we typically see both. So when you have the patients go into the procedure knowing that they're looking for even minor improvements in their standing time and walking distance, what we've seen with about 34 patients, improvements of 16 times. I'm happy if I get my patients twice the walking distance and standing time, and most of them are as well. So setting that expectation early and capturing those functional outcomes is critical for the success of the procedure. Next slide. So we've adopted this 2-step home conditioning guide, again, based on American Heart Association and evidence that is driven towards the conservative management of lumbar spinal stenosis with flexion-based activities for core strengthening. Physical therapy is something that is a continuum. I usually tell my patients, like a diet, if you try it one time and expect to have miraculous success, you're not looking at it for the right reasons. It's an ongoing modality that needs to be incorporated. If patients are, again, those candidates that do extremely well, they can proceed with this 2-step home conditioning guide. The ones that are on the fence or have not yet to respond typically get a coordinated physical therapy in-house. Next slide. So again, looking at what they can initially do prior to what you want them to do on a daily basis. And this begins really from post-op day 1. I encourage patients to ambulate, as much as they can tolerate the first few days. And then typically by the 3rd day, making sure that they are doing this dedicated walk for at least 5 to 15 minutes, stretching with the next slide, you'll see the stretches, and building on that every week. And this is really a fun part of the procedure, post-procedure, that patients get motivated by. So when they're able to see and track their progress, most of my patients now have iPhone capabilities, and we measure and look at that data when they come in for their post-operative visits. Next slide. These techniques can be done with no equipment and no facility. Obviously, I have performed this on patients who are severely deconditioned and can barely make it to their bathroom. I would not recommend those patients getting on the floor on their own. However, most patients that are ambulatory can perform these very easily, and it's not overwhelming for them to see. You don't want to get too involved with bands, with balls, with equipment for these types of patients who don't have the ability to utilize those. Again, looking at core strengthening, looking at hip flexors and lumbar stability. And all of these modalities address that. Next slide. So as Zora has been mentioning, and we really want to make sure that we're capturing outcomes. Looking at walking distance, standing time, these are metrics that are easy to obtain. Patients are willing to track that data, and the satisfaction will improve when they see those numbers increase. So we want them to self-monitor. We want them to be able to identify other pain generators and understand when they have aches or other ailments, it's not necessarily directly related to the spinal stenosis or neurogenic claudication. Next slide.
So great job, both of you. Thank you so much. Val and I both have a question for you, and then we're going to have closing thoughts. Alex, the first question from me to you. There's been a lot of questions from the viewers wanting to know, when you educate the patient, how do you decide, about doing the PILD procedure versus a spacer? And the other question that's very common, if you do the PILD procedure and it's unsuccessful or they progress with the bone, can you still go back and do a spacer later?
So this is a very common question. And what we have identified with MIST guidelines is that patients who are candidates for a posterior direct decompression are those that have evidence of ligament and flavum hypertrophy. Despite having other comorbidities in the spine, if there is a ligament in my practice that's thicker than 4 millimeters, I'm going to consider a posterior decompression first. I never anticipate a definitive therapy to offer another therapy. Therefore, I allow the patient to understand we aren't burning any bridges with this. However, we're not going to be quick to jump to a next treatment option if this one fails. I wait at least 3 to 6 months to consider, and in my practice, less than 10% of patients that have undergone a direct decompression have then went forward with an indirect spacer.
Sounds like you're very judicious in your decision making. I love that. Dawa, do you have a question?
Yeah, my question is for Zora. So, what advice do you have for, your fellow advanced practitioners? As in our practice, and I know in Tim's, you guys see a lot of these patients much more closely in follow-up post-operatively and during that, post-procedure period. And you touched on expectations. So, oftentimes, these patients may not be home runs immediately. What do you kind of tell your patients if they're still struggling in that initial, first 1 to 2 weeks, and what kind of things do you do to help them get through that period? And then when do you kind of finally say, maybe this procedure didn't work? At what time period? And maybe discuss other options.
Sure. So for sure, I think setting expectations is a big thing that I really push with, my patients, and even like my team, talking to the nurse, like when the patient calls, to just let them know that here's what we expect to see 2 weeks out, a month out, 3 months out. And I have that conversation early on with the patients too, as far as, sometimes you go through surgery and you might feel immediate relief. You may feel it with this, but it may also take time. Your body's been deconditioned for so long. We might get rid of some pain. It doesn't get rid of all pain and every kind of pain. So just really clarifying with the patient what they would expect to see and feel after the treatment. Incisional pain, which should be fairly minimal in that aspect, but I think the follow-up is important as well. Sometimes patients, they say they're doing well, so they don't come back to the clinic. There's no documentation of how they're doing, and then 6 months later they call and they haven't done well, or their expectations weren't met. So generally, I tell people it's important to set up follow-up appointments. It's important to make sure you're talking to that patient, keeping that kind of continuum of care as we talked about, so that you can help them along the path and along the way, 3 months out, 6 months out, and at least give them that clarification that, people generally do better within the year. We see better outcomes. It may not be immediately right after the surgery or even a month out. It takes that time and that effort from their end to also, do that therapy, do the walking, and kind of build that strength and support and conditioning. So that's, I think, really what I highlight when I talk to my other teammates, my nursing staff, our support staff and everybody else, to kind of set those clear expectations when a patient calls or there's questions. I apologize, you said you had a second question. I don't know if I answered that as well.
When do you just kind of tell the patient, yeah, this probably didn't work?
Yeah, so I mean, obviously we set those previous goals. What do you expect to gain, right? Are you walking to the mailbox right now? How far can you get to, with how many feet and things like that? I do try to ask ahead of time, because there's really a hard measure to identify a person's pain, right? A score can be one way, but when they tell you they're still at an 8 out of 8, but now they're walking in the mall for 30 to 40 minutes versus being able to even walk to their mailbox, I remind the patient, that this is what our goal was. We've kind of achieved at least that. How else can we, improve your function? Really, you might still have pain, but are you moving better? Are you able to walk and stand? If obviously they've not been able to accomplish that goal that we previously set, they're still very limited in their capacity to function. Obviously, then we would discuss with them alternative options and pursuing further treatment. But like Dr. Escobar said, it might be 6 months out before we see those changes, or even longer. So as long as we're not seeing a decline in that function, I think we try to give them expectation to give it time and really work towards that.
Can I add to that, if you don't mind? Real brief.
Sure, I was going to ask you a question about that before we broke up. Yeah.
Okay. I would just say that I wouldn't deem a failure of this procedure until I've identified or ruled out other pathological features. So at 3 to 6 months, we're trying to identify if there's any sacroiliac instability, if the patient has, any type of spondylosis causing, facet arthropathy. And if they respond to those modalities, it just suggests that there was likely another pain generator. So I would wait to see the response to alternative options and treatments that we typically perform before I deem this a failure per se.
I agree with that, because as people walk more, they notice other things. So as we've seen in some of our studies, as they get more active, their knee starts to hurt because they hadn't walked very far before. Alex, we'll give you the last question, and then we're going to have final thoughts. And really, it's really just a compilation of 2 questions from the audience. Could you, or should you, or would you put epidural steroids in at the end of the epidurogram at the end of this procedure to enhance the short-term outcome for inflammation while the mouth's kicking in? And should you change fellows to do this procedure? So I want to give me about a 15-second answer for both, and we'll wrap up.
Perfect. I routinely, every procedure, perform an epidural steroid injection with 4 cc's of 1% lidocaine and 10 milligrams of dexamethasone, preservative-free. I ensure that I check a lateral view, make sure my epidurogram is still consistent with epidural contrast spread, and every patient is getting an epidural steroid. I encourage you never to bill for this. You will get reimbursed for only the epidural steroid injection and not the procedure. So I'll eat the cost at our surgery center for that ESI, because I do feel like it has a significant indication for our patients. The next question was training fellows. Absolutely. I train fellows routinely at the University of Toledo. We have 2 every year. Like I mentioned, it wasn't until the very tail end of my fellowship that I was introduced to the technique, and everyone has different approaches to this. We have techniques that continue to evolve, and therefore when you finish fellowship may not be available, but we will easily and encourage you to seek the right training to be able to provide this effectively from the beginning, to not go through those steps where all of our other predecessors underwent that may have gotten frustrated with the technique. An improved technique will allow for effective treatment that you'll see outcomes that are reproducible.
Great. Thank you both so much. We appreciate you joining us tonight. Great job.
Great job, guys.
Thank you.
Dawood, we wrap up another webinar, and certainly it's been a great one tonight. I think the faculty's been amazing. I've been very impressed. I'll just close by saying that you have to make the diagnosis of spinal stenosis, and that's really critical, because if you don't make the diagnosis properly, none of these procedures will work. So take your time, review your images, talk to your patient. Advanced practice providers can be very helpful in making that diagnosis as they come back for follow-up. And then pick the right procedure for the right patient. And that's really important based on the anatomy. So with that, I'll give you the final thoughts of the night, and thank everyone for joining us tonight.
No, thank you, Tim. I think you're really spot on this. And I think, patient selection and looking at the evidence and the data will be key in, ensuring the success of this therapy. But I really do also look at this therapy as, one of the early steps potentially in the evolution of our field, from moving from beyond just, prescribing medications and injecting steroids to really treating underlying pathology. So I think this really is one of those kind of key moments in our history of our field where we may evolve with incorporating treatment like this and looking at painful pathology beyond just palliation. So I thank all the faculty. They did a wonderful job, and just want to make a few closing announcements. We have another really great webinar slated next week in headache management. Next slide, please. We're really excited to announce that a few of our kind of key events of the year are still going to go on, but in maybe a different venue, and we're going to go virtual. So the first will be our Aspen virtual think tank again. So this is going to be across 5 nights in mid-August. You can see the dates there, and this will be for Aspen members only. It's going to be moderated by the names you see there, and we're going to have really expert panels and really new, innovative therapies within our space, talking about things like new innovations in spinal cord stimulation, targeted drug delivery, SI joint fusion, peripheral nerve stimulation, radiofrequency, and minimally invasive spine therapy. So I think that's really going to be a different type of event, again, non-CME, and really kind of an open discussion about a lot of these therapies. So I think people will really be interested to kind of tune in and see that. Next slide. And then, we're making a big decision, about our annual meeting. This was slated to be in late summer, and we moved it down to September to be held, in person in Miami. But with, the recent spread of the disease, and especially in the state of Florida, we've made this decision to also make this a virtual event. So more details to follow on this, but the same dates will apply, the same faculty, the same topics. But we really hope to do this in really a unique virtual platform. We're going to tease some of the ways we're going to do it. It's going to be much more than just a webinar. It's going to be very interactive with all key faculty. So more to come there, but the meeting will go on. It'll just be in a different way. And we hope that we can actually have much more people involved, both as faculty and as attendees, by being able to go virtual. And just a final announcement on CME. You have 48 hours to claim your CME through Dana Miller. Here's the link. And this lecture will also be posted on our YouTube page. Next slide. And with that, I think we're good. Thank you, everyone, for your time. Tim, if you have any closing thoughts, please. If not.
Nope, that's it. Good night, everyone. See you soon.
Thanks, everyone. Good night.